Well, good morning, everyone, and welcome to Pediatric Grand Rounds. I have to say, although the drive in this morning was a little bit interesting, I can report that here in the broadcasting studios of the Children's Hospital of Pittsburgh, it's a beautiful day, 72 degrees, not a cloud in the sky. A wonderful morning for Grand Rounds. I'm real pleased to be hosting this update on COVID-19, now almost a year into the pandemic. And I thought I'd just share that this has been a very eventful week for us with regard to COVID-19. In Allegheny County, our 5-day rolling average is about 1,000 new cases a day. That has doubled in the past 2 weeks. We now have a total of 43,000 cases of COVID-19 diagnosed in Allegheny County. That's about 3.5% of our population here. We're busy at UPMC. We've got about 1,200 inpatients across the entire UPMC system. That's about 22% of our bed capacity. We're busy, but we're coping, open, safe, ready to provide care. And finally, this week we started COVID-19 immunization, an incredibly exciting development, our first step really at putting this pandemic in the rearview mirror. And I was thrilled to see our very own Sylvia Owusu-Ansah on the front page of the New York Times, being immunized by Tammy Minier, head of the Wolf Center, who leads our COVID-19 task force at UPMC. An eventful week indeed. And it's that backdrop that this morning we're going to hear 3 exciting stories about COVID-19. I'll introduce all 3 speakers now. They'll share their thoughts on their topics, and then we'll have time for questions at the end. So first, let me introduce John Williams. Dr. Williams is the Henry Hillman Professor of Pediatrics and Director of the Division of Pediatric Infectious Diseases at UPMC Children's Hospital of Pittsburgh. He earned his MD degree from the Medical College of Virginia and completed pediatrics residency here at UPMC Children's and Pediatric ID Fellowship at Vanderbilt. Dr. Williams is a world expert in respiratory virus pathogenesis and immune responses and has been a frequent source of wisdom about the COVID-19 pandemic. Even Sanjay Gupta himself asked John for advice. Because of his expertise, Chancellor Gallagher tapped John to serve as the director of the COVID-19 Medical Response Office for the entire University of Pittsburgh. And John's going to talk about the Pitt response to COVID-19. Now, following John, Dr. John Alcorn is going to present. Dr. Alcorn is Associate Professor of Pediatrics and also Immunology. He is housed in the Division of Pediatric Pulmonology. He's also Associate Director of the R.K. Mellon Institute for Pediatric Research at UPMC Children's Hospital. Dr. Alcorn earned his PhD degree from Duke University and completed postdoctoral training at the University of Vermont. Dr. Alcorn's current research focuses on how the lung responds to bacterial and viral infections and molecular mechanisms of asthma. Dr. Alcorn is going to give us an update about COVID-19 related inflammation and therapeutics. And then finally, Dr. Maya Ragavan is going to present to us. Dr. Ragavan is Assistant Professor of Pediatrics at the University of Pittsburgh School of Medicine in the Division of General Academic Pediatrics. She earned her MD and MPH degrees from Northwestern University and completed her pediatrics residency at the Lucile Packard Children's Hospital in Palo Alto. She trained in general academic pediatrics at Boston Medical Center and earned an MS degree during her fellowship training at Boston University. Dr. Ragavan is a health services investigator with interest in intimate partner violence and healthcare delivery. Dr. Ragavan will discuss the Pittsburgh Community Vaccine Collaborative. This is a community academic collaboration to build trust in SARS-CoV-2 vaccines and vaccine trials. Now, I have asked this outstanding group of speakers to spend about 10 to 15 minutes on their topics, which is going to leave us a good deal of time for discussion. So please post your questions in the Q&A, not the chat function, but the Q&A, and I will try to get to as many as I can. And those that we don't have a chance to address will be discussed in the follow-up session after Grand Rounds. Thank you, and welcome, Dr. Williams.
Well, Terry, thanks for that kind introduction. and thanks for inviting me to speak here about the work of many people, of whom I am just one member of a large group of people who were tasked with controlling virus on the University of Pittsburgh campus this fall. So let me go to my slides. And everybody can probably imagine, the challenge is, how do you control virus spread and outbreaks in a campus with 30,000 people? And Pitt has about 30,000 students, 2/3 undergrad, 1/3 graduate, and this was a large undertaking that we started back in the spring. And I'm kind of give you the 20,000-foot view. So the university formed a number of committees. I'm just showing you 3 here that are directly relevant to the medical aspects in virus control. One was the healthcare advisory group chaired by the dean, Anantha Shekhar, and this is a group that devised a lot of the policies on what to do, how to have a university life amidst a pandemic, and to try to do so safely. Then the Implementation and Oversight Committee, and Chris O'Donnell has been an essential, from the Department of Medicine, a professor, has been an essential partner in all of this. And we developed ways to implement the policies that the Healthcare Advisory Group designed. So how do you actually make it happen? And we have members on that committee from Department of Psychology, Graduate School of Public Health, all over the university, engineering. And then sort of the public health department for Pitt is the COVID-19 Medical Response Office. And this is the term the chancellor coined for us, the public health department. And that's really, I think, the best way to think of us. We don't provide medical care. We don't provide medical advice. Our goal is to, try and control spread on the campus. And our major tasks were mitigation practices, testing, contact tracing, isolation, quarantine, and advisories. And I'm just going to give you the sort of bottom line up front, is that the key is communication with students. And our students here at Pitt are terrific, because I'm going to show you it can be done without doing a million tests. And I'll tell you why that's important. So for mitigation, I'm just going to show you a couple slides on this, but these were the kinds of things that we tried to convey to people. All of you have been hearing this for months, but 6 months ago when we started this was really new to people. Number one is face coverings. And I tell everybody this: if you refuse every other aspect of mitigation, just wear a mask. If you're going to cheat on anything, cheat on distance, not the mask. Number 2 is the social distancing, and number 3 is hand hygiene. But I mean, the mask really trumps hand hygiene. And enhanced cleaning, I have in gray font because it's actually relatively unimportant. There's almost no evidence of transmission of SARS-CoV-2 from inanimate objects like doorknobs and light switches. The virus does not live very long on these surfaces, and we're wasting an enormous amount of effort cleaning ourselves into a frenzy instead of just putting on a mask. So these are messages that we try to convey to students. Okay, so you really have to have a multi-pronged communication strategy, and I could spend a whole hour talking just about this. This is really the heart of what we did on the Pitt campus, and I think there were 2 aspects of it that made it successful. One is that we had all these different ways to reach people. There was an actual marketing campaign with slogans, the power of Pitt, and graphics. We had lots of town hall conferences with Q&As with students, with parents, with staff, with faculty, etc. We used every messaging route that we could find: email, text, all the social media. We had student safety ambassadors that were hired, several hundred of them, to go out and engage with their fellow students. We had the RAs and residential directors that we worked with and trained, and student organizations like Greek organizations, clubs, student government, every way that we could engage with the students. And this is really important because while one might think that to educated people, you could just give a message once, our experience in the hospital with hand hygiene shows that isn't true. None of us should be told more than once that we need to clean our hands before and after every patient encounter. Yet you see the report cards on patient hygiene, we have to be reminded constantly. And so that was one aspect that was very successful. The other is that it was interactive. We didn't just dictate from on high in the ivory tower, hey students, this is on you, good luck. No, we had student members of all of our committees, we got solicited student feedback. It was really a two-way exchange of information, and we changed policies and practices in response to the students, because our goal was not to tell the students what to do. Our goal was to help the students find the way to do the right thing. Very analogous to our partnership with our patients. We can order our patients to do what we think they should do, or we can work with them as partners for their health. That turns out to be a lot more effective. Other elements that I'm not going to spend much time on: contact tracing. Of course, we hired lots of contact tracers through environmental health and safety. We hired a lot of graduate students. Some, if any medical students are listening, some of you served, thank you. We had a whole team of quarantine isolation, and this included dedicated isolation housing, a COVID support team based out of Student Life that checked in on students in isolation every day, delivered them food, did their laundry, really worked closely with them so they weren't lost and alone. And then COVID testing, and we focused on three kinds of testing. One, symptomatic, students, staff, and faculty. One, surveillance testing, which is important. I'm going to spend a little time on that. And then close contacts and focus cluster testing. Close contacts, obviously anybody who's been within 6 feet, more than 15 minutes of a SARS-CoV-2 positive individual. And then focus cluster is if we had several cases in, say, a residence hall or a student organization, even if there wasn't an obvious link, like they were on different floors of the residence hall, we just tested the whole building. Okay, so for our large-scale testing plan, we developed a classic epidemiologic method of systematic random surveillance testing. And the goal of this is to sort of have a finger on the pulse, to know what's happening with, in this case, SARS-CoV-2 infection, but it could be any disease, and yet use resources wisely. So we worked with statisticians in the Graduate School of Public Health to determine how many students did we need to test to have a plus or minus 1% confidence estimate of the point prevalence. It turns out that number is about 10%, but we didn't pick 10% out of the air. This is how we got there. And during move-in, we were interested in, is there different risk depending on who you are as a student? And there were basically 8 groups: students from Western Pennsylvania, the rest of the state, the rest of the US, and international. At that time, back in August, there were different hotspots. Now every place is a hotspot. And then on and off campus students. I will say, a lot of people said, oh, you got to test everybody coming from Florida. It's not where you go, it's what you do when you're there. So if you were in Florida in the summer and wearing your mask and distancing, you were a lot safer than if you were in Lawrenceville going to bars. And in fact, when we brought the students here, most of our positive cases that came were from local students, not students from hotspots. So we faced a lot of questions. Why not test every student? Why not do everybody? Well, the CDC and the American College Health Association specifically recommend against that. And there are several reasons. The biggest reason is in bold font there. False negative results provide an inappropriate sense of safety. Many studies show this for lots of diseases, and it's just human nature. You get a test, you think I'm negative, and then people are less careful about mitigation, and they feel like I can go out to a party because I'm negative. And the problem is, in the first 4 to 5 days of SARS-CoV-2 infection, everybody tests negative. Everybody who's infected is going to test negative for a number of days because the virus is too low. And if you want evidence of the failure of frequent testing, you can just look at professional sports, collegiate sports, and the White House. And I'm not making a political statement. I'm just saying testing all the time is not enough. And then, as you know, there's a national testing resources are not adequate. If there's a lag time in testing, which many times there is, if you're testing thousands and thousands of people a day, that really compromises the value. So I'm not going to go through this slide in detail. Essentially, we brought students, instead of all coming at once in a few days, and many of you have seen Pitt move-in day, like every college, it's madness of 20,000 students coming in a few days. We brought them back over 2.5 weeks, and we tested along the way, a subset every day. Now, the way we did this was to build a large mass throughput testing site. Some of you may have seen us. It's down at Post Far Hall. We've moved it indoors now for the winter, but it was this setup, and then it was a tent for a couple of months. And essentially, I'm going to very quickly walk you through that. Students check, they're invited online to come in and test, and they schedule their appointment. They come and check in line. They wait through the line. You can see on the ground there are marks that are socially distanced. Here's Chris O'Donnell testing it out early on. This is with a very small number of people there on one of the early days. We can process 100 people an hour through the site. As they're waiting, they see a video showing how to do a self-collected nasal swab. And this recapitulates an instruction set that they had sent out to them with the email. About half of the students have logged on and watched the video before they came, so they know what to do. If they haven't, they can see it while they're waiting. Then there are test booths where our trained observers in PPE guide the students through self-collecting their own nasal swab in a distanced, safe fashion. The student sits there and they have these placards to show them exactly what to do, and a mirror, and here's all our sterilization stuff to clean afterwards. Then the student barcodes their tube and drops it in the cooler. Start to finish, maximum is about 10 minutes. It's often closer to 5. So it's very, very efficient to process these students through. And then the cooler full of samples gets taken up to the lab. The samples get pooled on this pipetting robot. So we take 4 specimens and combine them into one and test that pool. We still have the original specimens. So if that pool is positive, we can go back and test the individual samples. So this is, 96 samples then combines to 24. So this is 192 samples combined into 48 pools. And then we test the samples by different molecular tools. Essentially, they're all kind of PCR based, and that is the gold standard, a PCR on a nasal swab. Every other test, saliva, rapid antigen, they're all less sensitive. And here's just an example of what the data looks like. So this is a pool that tested positive, and we went back and pulled out the 4 individual samples. We don't have to go back to the students, and that one student tested positive. So this enables us to very efficiently test a large number of students. And here's all the people at the site team. Boy, that sunny fall day, late summer day looks pretty good right now. Joe Suyama, who's an ER doc, is the head of the testing, and he's a whiz. And then one other person to shout out, Terry Sachs. We have several data people, but she is a data maven. So how did it go? I'm just going to show you a couple slides of how this is compressed our dashboard for the whole semester. We had a little bump right after the students came. We communicated with them. Hey, people, numbers are going up. You got to rein it in. And they settled back down. And we did great all through the semester. We actually opened up to a more open posture. And then this is post-Halloween, and we expected a bump when we saw Halloween gatherings happening. You can see this really at the end. We were lower than the county, but it was paralleling what's happened in the fall everywhere. So here, are the final numbers that of symptomatic students, we tested 3,000 in student health, and about 12% overall were positive. It's a really important thing to remember, and it's why mitigation is so important, is that on any given day, people that show up with symptoms of acute respiratory illness that make you worry about COVID, most of them don't have COVID, they have something else. So you have to constantly be vigilant. In our random surveillance, the prevalence was very low. And this told us that we weren't seeing silent, under the radar, widespread circulation. And then close contacts and focus testing. So overall, we did 11,000 tests. How does that compare to other schools? So I'm putting here for comparison other schools that took a mass testing strategy approach. And I'm just showing you the undergrad enrollment and the dates. This is public data available from everybody's public dashboard. So you can see these schools are all similar size to we are. So here's the number of positive tests each school had, from a low at Duke, 150, to a high at Penn State of over 4,000. Here's normalized to the number of students. So the positives per number of students, we did extremely well. The number of tests performed. University of Illinois Urbana-Champaign, 1 million tests. And then the number of tests per 10,000 students to yield essentially very similar, or in many cases, better results. And the reason that's important is, these resources that are used for testing are resources that are not used for other things like scholarships or hiring faculty. So it's important to be thoughtful about the use of resources. So to conclude my part, you have to have multiple university groups involved. It's an all hands on deck response. Testing alone is not enough. We had people from all these groups, and the student behavior is key. And our students, the Pitt students, did magnificently. And they deserve really the lion's share of the credit for a successful semester. And then I'm not going to go through this, obviously, but I probably am still missing people on this slide. It takes a city, not just a village. So I'm going to pause there, and John Alcorn, I'm going to turn over to you.
All right, thanks, John. Now we're going to talk about something a little bit different. I'm going to take us through both the positive and negative aspects of the immune response to SARS-CoV-2, and then a brief little update on a couple of therapeutics that are treating hyperinflammation in the disease. Okay. Oh, sorry. Am I muted?
We can hear you now, John.
Okay, sorry, I don't know what's going on there. All right, so I just have one disclosure here. I'm going to talk a bit this morning about the beneficial and the detrimental effects of host immune activation during SARS-CoV-2. And then we're going to talk about a few therapeutics that have been tested in large cohorts. Okay. All right. So the initiation of inflammation during SARS-CoV-2 is a complex process that involves binding of the virus to its receptor ACE2 on the surface of most of the epithelial cells in the lung. ACE2 is internalizes the virus through furin protease cleavage by this protease TMPRSS2, which leads to viral replication and production of both DAMPs and PAMPs, meaning both viral RNA, but also damaged cell DNA that activate the immune system. At the early stages of immune activation, viral RNA triggers pyroptosis in the cells, which is a process by which the inflammasome produces IL-1 to initiate a host response. So as this proceeds, the infected cell dies, and additional inflammatory cascades are activated through production of a number of inflammatory cytokines. They're listed here, IL-6. These are macrophage inflammatory proteins, MIP-1 and MCP-1, and T cells recruiting cytokines such as IP-10. The response then is manyfold in terms of cellular recruitment. Both monocytes and macrophages come to the tissue where they are activated to clear dead cells and also to address the virus. T cells, both CD4 and CD8 T cells are recruited. The CD4 cells help in priming antibody responses down the road, but also activate CD8 T cells to kill infected cells. And then neutrophils, which are not depicted here, come into the tissue as well to defend against the virus. One thing that's important to remember here is that the normal immune response does have this positive feed-forward mechanism where inflammatory cytokines and chemokines drive recruitment of inflammatory cells, and the inflammatory cells then secrete additional chemokines that drive the inflammatory process forward. So when this is working well, the goal of host inflammation is to clear the virus and clear infected cells. And this is done in many ways. In the primary mechanism, CD8 T cells and natural killer cells are able to recognize infected cells and lyse them through granzyme and perforin and other protein products. CD4 T cells, as I mentioned, help with this process, but also activate B cell immunity. And that generates monoclonal antibody against the virus, which would then be able to neutralize the virus or bind to it, and through phagocytosis activate macrophage uptake of neutralized virus in the tissue. So this is kind of the picture of what we would like to see. We get infected cells being cleared, the virus is being inactivated by neutralizing virus, but this does take time. And if proceeding appropriately, there's minimal damage to the lung or the tissue. However, in some patients, this proceeds towards detrimental inflammation. And this virus, SARS-CoV-2, activates cytokine storm akin to what we've been talking about for years with influenza in the host. And what we mean by that is overproduction of these pro-inflammatory cytokines. such as IL-6, CXCL10 here, IP10, interferon gamma, and others, IL-1 as well. And what happens then is the inflammatory cells become detrimental. Macrophages and neutrophils secrete products that can cause damage to the tissue and kill not just infected cells, but also cells that are non-infected. And this process is mediated then by both reactive oxygen species, reactive nitrogen species, proteases, and other proteins that cause cell death. So what we see then is the epithelial barrier here depicted in these kind of dead and dying cells that are infected starts to break down, and gaps are formed in the tight junctions at the airway surface. This then leads to a leak from the vasculature. And in the context of SARS-CoV-2, the virus also can attack the endothelium in the lung. This then leads to greater greater edema in the tissue and loss of lung function over time. The accumulation of inflammatory cells then also can lead to additional damage through basically non-protective mechanisms of inflammation. So you start to get these chronic breakdown of tissue. And this may be what's being triggered to an extent, even in long haul COVID, where the virus itself may be cleared or at low titers, but there's persistent inflammation that's occurring in the tissue that continues on well past the viral window of clearance. With SARS-CoV-2, as I mentioned too, it's not just tropic. It's unlike flu. It's not just tropic to the epithelium of the lung. It can also bind to other cells throughout the body. So in this syndrome in COVID-19, we also see widespread inflammation throughout the body in some patients, including multi-organ damage to the kidneys or liver and other tissues as well. So the first class of how we may manipulate this pathway is broad steroid treatment. In this case, dexamethasone. This cartoon illustrates how corticosteroids affect the host cell or inflammatory cells. They bind to the receptor and alter transcription in the nucleus of inflammatory genes. And steroids, dexamethasone particularly, are able to suppress a number of cytokines, including TNF-alpha, type 2 cytokines depicted here, but also type 1 cytokines as well, IL-1 and IL-6. And at the same time, corticosteroids stimulate the production of anti-inflammatory genes, such as IL-10, decoy receptors for IL-1 that bind the protein and keep it from driving inflammation. So the principle here is basically a blunt tool to block inflammation, generate greater anti-inflammatory mediators, and decrease the inflammatory mediators over time. So how has this been working? So this has been tested fairly early on in this recovery collaborative group that published in the New England Journal of Medicine. What they did here is they treated with dexamethasone in COVID-19 patients. And what they found was a significant reduction in mortality overall in those patients with a rate ratio of 0.83. They actually found when they looked in subgroup analysis that those patients that required invasive mechanical ventilation had a larger effect of dexamethasone treatment on mortality. And similar was found with those that were on oxygen only. However, in patients that were less severe, that had no oxygen delivered, there was actually potentially even a detrimental effect of dexamethasone. So it seems that this kind of blunt tool of blocking inflammation is most likely useful in severely ill patients. This then has been studied further. And this is a study published in JAMA, a meta-analysis of all of the studies, and it includes the recovery study that I just showed here. And this is several then studies that combine together with an overall net effect here in the green box right here of about a 0.66 odds ratio, or about a 30% reduction in risk of mortality with dexamethasone treatment. So the WHO in September issued a recommendation that you can find if you Google it to recommend dexamethasone treatment in severe COVID. So I said we'd move on kind of to more immunomodulatory therapies. And in this case, we'll talk a little bit about IL-6. So the use of steroids is very much a blunt tool, blocks inflammation in general, whereas we would like to be able to tune inflammation more specifically to block detrimental cytokines and maintain the protective functions of the immune system that I mentioned before. IL-6 is a pleiotropic inflammatory cytokine. It's produced by the endothelium, it's produced by epithelial cells. It can activate the immune system through monocyte recruitment, as depicted here. So IL-6 is able to complex through JAK signaling and produce a monocyte chemotactic protein, which brings inflammatory monocytes to the tissue. This can be a detrimental pathway, as these monocytes have been shown in context of influenza to be quite detrimental in terms of lung injury, and that they drive a lot of the tissue damage that's going on. In addition, the IL-6 can be beneficial, can drive neutrophilic apoptosis, but if we have too many neutrophils in the tissue, neutrophilic apoptosis can generate damps in these molecules that are recognized by the immune system to drive further inflammation. So what we've seen then over time is this idea of repurposing anti-IL-6 drugs in COVID-19. So the rationale for this is based on the fact that IL-6 is indeed elevated during severe COVID-19. So this is another meta-analysis with over 8,719 patients across multiple publications. And what you can see is about a weighted mean of about 23.86 increase in severe COVID patients versus mild COVID. So this is the evidence for potentially blocking IL-6 in the disease. So a recent issue then of JAMA Internal Medicine was focused on the use of an anti-IL-6 receptor blocking antibody depicted here. And there were several studies then published across multiple sites to determine whether anti-IL-6 would have an effect. This first study actually looked at clinical worsening as a primary outcome and found no effect of anti-IL-6 receptor therapy. However, if we look at mortality as the primary endpoint, there was a significant benefit of treatment with anti-IL-6 therapy in those that were requiring oxygen and were not on mechanical ventilation. So then in total, again, this is a large-scale critical study where we looked at patients that were looked at in the first couple of days in the ICU. Again, in these type of patients in the ICU, anti-IL-6 receptor therapy was beneficial in terms of preventing mortality. And this is a very small text here, but at the very bottom here, I can read to you. This is corticosteroid treatment on ICU admission. And what they found over here in odds ratio is that the anti-IL-6 receptor therapy had similar effects both in the presence and absence of steroid therapy. So this was an important finding in terms of adjunctive therapy use of anti-IL-6 receptor. And then finally, in the last couple minutes, I'll talk a little bit about a different cytokine, IL-1 beta, which is produced by the inflammasome, and it drives wide-scale inflammation in tissues. IL-6 is important, IL-1 drives IL-6 production, but also drives protease production that remodels tissue, and a number of other factors in terms of just inflammatory lean overall, including neutrophilia via IL-17. As you may be aware, anti-IL-1 beta, there's a receptor blocking drug already licensed, anakinra. And in this case, anakinra was tested in COVID-19 ARDS patients and has shown some benefits. What's depicted here is this is a PaO2, which has been increased, but more importantly, patient survival with high dose anakinra was actually much higher in this study published in Lancet than without treatment. And that was also true then for mechanical free days. And additionally, IL-1 provided a benefit, anakinra provided a benefit. All right, so this is by no means then a complete discussion of what's been being studied. So I've talked a little bit here today about corticosteroids and their broad anti-inflammatory activities and how that has been used in COVID. We talked about anti-IL-6 receptor and anti-IL-1 receptor and how these can prevent cytokine storm. There are many other ongoing clinical trials in the literature already. The JAK inhibitors have been of particular interest recently, and then several other drugs in terms of how interferons or GM-CSF, which promotes recruitment of inflammatory cells and growth of inflammatory cells in number, may prevent inflammation during the disease. Okay, I will stop there and I will pass the torch over to Maya.
Maya, if you would unmute and perhaps change your display settings over to your presentation mode.
There we go.
Perfect.
Perfect. All right. Thank you so much, everyone, for the opportunity to talk today about the Community Vaccine Collaborative. So I have no disclosures. So the Community Vaccine Collaborative is a Pittsburgh-based partnership among community-based organizations, community members, health systems leaders, researchers, and the public health agencies. And so we convened in July 2020, just when the COVID-19 vaccine clinical trials were getting started at the University of Pittsburgh. And our original goal was focused on ensuring equitable inclusion in the COVID-19 vaccine clinical trials of traditionally underrepresented and excluded groups, such as those identifying as Black, Latinx, as well as other groups. And while that is an incredibly important goal in and of itself, this group has also expanded beyond that particular goal, as I'll be describing during the presentation. So the CVC is co-led by 4 community-based organizations, the Urban Kind Institute, the Urban League of Greater Pittsburgh, Casa San Jose, and the Neighborhood Resilience Project. And these 4 organizations, among many others, but these 4 organizations have been really on the forefront of supporting Pittsburgh communities during the pandemic by providing on-the-ground information and services, distributing life-saving resources, including food and masks and protective equipment, and conducting virtual information sessions for the community. So I think it's really, really fitting that they're the ones that co-lead this effort. Other partners include UPMC, the University of Pittsburgh CTSI, as well as the Allegheny County Health Department. And I just want to pause for a minute here and sort of share the full list of CVC members. And this is a continually growing and expanding list, but I think it's just really important to include everyone who built and continues to build the CVC. And aligned with sort of this idea of co-owned messaging and co-owned ideas, I really see myself as a messenger here. So I just wanted to make sure that everyone who's part of the CVC is credited during this presentation. And so, like I mentioned, the CVC convened in July of 2020. And I think what's really innovative about this group is that it is greater than 50% community partners. So while researchers play a role, it is mainly a space for community partners. And our meetings have discussed the pandemic, how the pandemic disproportionately impacts marginalized communities in Pittsburgh. We've also talked about vaccine trials, and now we're making the shift to talk more about vaccine safety, efficacy, allocation, uptake. And one of the goals of the CVC is to really support the incredible work being done by communities and spotlighting community level resilience. And so one of the examples is we've worked closely with community health deputies through the Neighborhood Resilience Project to spotlight their work, which who I'll be talking about in just a moment. And so the CVC has really focused on 2 main areas to date, vaccine trial recruitment and then building trustworthiness. So I'm going to be talking about each of those one at a time. I'll discuss the vaccine recruitment first. So the CVC has spent a lot of time thinking about how best to include and represent traditionally excluded groups in the COVID-19 clinical trials, particularly centered on community-based efforts. So we all know that mistrust of research is pervasive, and it's rooted in structural racism, historical trauma. And so we've brought together community leaders and researchers to discuss mistrust and brainstorm ways to make sure that the clinical trials are more representative of Pittsburgh communities. And so I really want to take a moment here and spotlight the community health deputies who were featured in the New York Times. This is the article, as well as Dr. Bay and the Urban Kind Institute. And so the Community Health Deputies is a program run through the Neighborhood Resilience Project. This is a picture of one of the community health deputies, as well as Father Paul Abernathy, who's the executive director of the Neighborhood Resilience Project. And they have been doing incredibly life-saving work in communities in and around Pittsburgh, focused on providing accurate and trusted information about the COVID-19 pandemic to members in their own communities. And there are about 100 different community health deputies who live and work all around Pittsburgh. And so they've been having bi-weekly meetings to reflect on what they're hearing and seeing during the pandemic, as well as learning from each other and from other experts. And members of the CVC have had the privilege to take part in these meetings and be part of that space and learn from the community health deputies, as well as share information with them about the clinical trials, as well as vaccine safety and efficacy. And as part of their work, they have also supported communities in signing up for the trial registry. They've just done so much amazing work, and I just really wanted to take a moment to spotlight them and thank them for what they've done. The other thing that we have done in the CVC is really think about creative ways to convey information about clinical trials, as we know that understandable and approachable information is critical to promoting health justice. This is an example of an infographic. So this was created by Janelle Young from the Irving-Kind Institute. And it describes the process of joining the vaccine trial registry, what information is needed, what happens after you join, and has been sort of distributed and used to share with people what it means to join a registry. And sort of kind of thinking then about how that work is translated into representation in the trial registry. So this is demographic information about the Pittsburgh Vaccine Clinical Trial Unit Registry provided by Dr. Martin. And so this data is as of early December of this year. And you can see that about 13% of the registry identify as non-white. In late July, it was about 5% who identified as non-white. So we don't know exactly where people heard about the registry or why they decided to join, but I think this slow and steady change over time is encouraging. Certainly there's more work to do, but is encouraging and really reflective of the work of the community partners. And then thinking about the clinical trial, the Moderna trial in particular, so this is demographic information about participants at the Pittsburgh site, also provided by Dr. Martin and her team. And you can see that about 27% of trial participants identify as non-white. And so that's also, I think, incredibly encouraging and far exceeded the national benchmark set by the NIH. And so now I want to shift over to the other area that the CVC has really focused on, which is trustworthiness of vaccines, of research, and of medicine in general. And so we have this idea of trustworthiness emerged almost immediately and very organically, and something that many of the CVC members have wanted to spend time thinking about. And our how we've conceptualized trust and trustworthiness is really thinking about this paradigm shift away from educating communities about why they should trust us as medical professionals, as researchers, to building up these institutions as trustworthy. And so we've really spent time, like I said, talking about mistrust, hearing from community partners, and using the CVC as a way for community partners to comfortably challenge research and challenge medicine and talk about what they've been hearing and seeing. And certainly these ideas have been discussed by communities, by scholars, by leaders around the country. So this this recent LA Times article also discussed sort of thinking about how researchers and healthcare providers can acknowledge and sit in and reflect on past mistrust and then rebuild and restructure as trustworthy. So I just want to acknowledge that our thinking is very well aligned with thinking of communities around the country. And so one of the things that we've done through the trustworthiness component of the CVC is launch a community-based and community design survey on COVID-19 and trusted information sources. So this is a survey that was designed by the CVC. It is specifically for adults in the Pittsburgh area who identify as Black and or Latinx. And the questions focus on where participants get information about COVID-19, how trustworthy these sources are, and their thoughts about COVID-19 vaccine uptake. And this survey is available both English and Spanish. And so we actually just launched this on December 1st. So I pulled data from December 10th to share. So I just want to put the caveat that this is quite preliminary, and this is data from December 1st to December 10th of the first 157 participants, 103 who identify as Black and 54 as Latinx. And so these are the local sources of information where participants said they get information about COVID-19. So you can see the majority, it's the news, friends or family, and then doctors and healthcare providers, about 50%, the health department, as well as community-based organizations. And then you can see other sources where people get information listed after that. And then when we're thinking about state, national, or international sources of information, so the cable news and the governor and Dr. Fauci were sort of the highest in terms of where people are getting information. And then you can see some other sources. And I also want to point out, while it's a small group, people are also saying that they're getting information from leaders of other countries as well. And we also asked participants about how trustworthy these sources are. And while I don't have that data now, and I'm excited to present it in the future, I think just sort of knowing where people are getting information is very important. And then we also asked participants about their thoughts on the COVID-19 vaccine. So again, this is data from December 1st to December 10th. And so 42% of participants who identified as Black and 63% who identify as Latinx said they definitely or probably would get the COVID-19 vaccine. And 37% who identify as Black and 67% who identify as Latinx said when a COVID-19 vaccine is available for their child, they would definitely or probably have their child vaccinated. And so, you know, reflecting on this data, I'm sure you are reflecting as well, and you've probably seen similar national data that kind of has that's, you know, similar aligned with what we're finding locally. You know, certainly mistrust is pervasive, and I think it is, but I think there's room, and it's encouraging that, you know, there's room to move the needle. And I think it really makes me grateful for the work our community partners are doing of acknowledging and discussing mistrust and then providing sort of safety and efficacy data about the vaccine, and really also leveraging community resilience to sort of address mistrust. I think that's so important. It also makes me really grateful for the work that all of my colleagues are doing and that all of you are doing about hearing families' concerns about the COVID-19 vaccine and then providing information that is trustworthy to families who are concerned. And I think that this is really a work in progress, and there is a need to both sort of urgently, but also intentionally move the needle forward. I also want to just say, I completely recognize that the groups Black and Latinx are not monolith. And when we do future analyses after we've finished collecting data, we'll be able to look more deeply at people's identities and how that sort of impacts their responses and their thoughts and feelings on these topics. But so I just wanted to recognize that we'll be able to look at further nuances in the future. So just to finish up, I just want to share a little bit about what we're working on now. Taylor Scott, who is a health advocate at the Urban League, is leading a project designing a survey for researchers on how researchers understand past histories of research trauma and how best to restructure research institutions. We've also sort of begun to shift from sort of trial recruitment, although, you know, we're still working on that, but also focused on vaccine safety and efficacy. So really focusing on messaging and creating trustworthy messaging through videos, through infographics and town halls. We're also continuously working closely with the community health deputies. Actually, the community health deputies led by Ms. Tyra Townsend will be 10, I think, community health deputies will be going through a training to learn more about vaccine safety and efficacy so they can bring that information back to the communities where they work. We are continuing to build the CVC, so wanting to bring in expertise, both community level expertise and also research multidisciplinary expertise. So really trying to include folks with social work, public health backgrounds. We've also included artists in our group to sort of help with the messaging and the videos. So trying to build the CVC. We are looking toward attending more to language justice and inclusion of English learners. The CVC has primarily run in English to date, but Benjamin Gutzchow from Casa San Jose, as well as Dr. Diego Chavez and others are working on developing town halls in Spanish and other languages to really attend to language justice and make sure English learners in Pittsburgh are included in these efforts. And then I think just continuing the conversations. And while I think the CVC has accomplished so much, I'm so grateful for the fact that we have taken the time to hear mistrust, taken the time to have these conversations. And I think, for example, one of the things that we did is we had an opportunity where researchers were asked questions by community members, sort of shifting the paradigm where researchers are the ones that ask questions to community members and making sort of researchers vulnerable in this space to share why they went into research and what their thoughts are about research mistrust. And so I think conversations like that are just so valuable, and I'm so thankful that the CVC is a place to have those conversations. And just to finish up, I wanted to end by sharing descriptions from CVC members about the CVC, making sure that really they have the last word. So I just asked CVC members to share what the CVC has meant to them or what they think it is. So just a few thoughts. So B. Schindler from the CTSI said, I appreciate the attention we have given to positionality, where we ask those in power, i.e. the researchers, to share why they are in this work and why do they set aside time to work with the collaborative. Taylor Scott from the Urban League said, we understand that conversations do not fully undo the harm that the Black, Brown, and Indigenous people have endured over 400 years. Changing the approach and looking to researchers and medical providers to be engaged in this work is vital. Father Paul Abernathy said the way in which the CBC has empowered researchers and community members alike and fostered a spirit of unprecedented collaboration between the two stakeholder groups in a time of great crisis provides direction and hope for the future of medical research, especially as it relates to justice and equitable healthcare. And then Felicia Savage-Friedman from Yoga Roots, as well as the Pittsburgh study, said CVC is a powerful nexus of committed grassroots community advocates and committed university and research advocates coming together to speak honestly about research's violent and past and present with research on vulnerable Black and Brown people and poor white people. In Pittsburgh, to my knowledge, this intentional cultivation of space has never taken place until now. I'm faithful that one day vulnerable peoples will be able to fully hold researchers accountable for all that they say and do. At that point, true trustworthiness shall be a lived reality instead of just rhetoric. So thank you again. If you have any questions, feel free to email me or Victor Muthama, who is the project coordinator for the CBC. Thank you.
Wow, terrific. John Williams, John Alcorn, Maya Ragavan, what great updates about COVID-19. I'd be grateful if you all would post your questions in the Q&A. And then Noel Zuckerbrand is going to be hosting a meet and greet with all the speakers from 9 to 9:30. So if you have additional questions, please feel free to ask them. John Williams, the first question from Jen Zarrett goes to you. And the question is, what are the thoughts on the new at-home rapid testing approved by the FDA?
Yeah, it's a good question. There are two sort of at-home or very point-of-care tests approved by the FDA. I think the one that Jen is asking about is they just approved in the last week or so a completely at-home, no prescription needed, buy over-the-counter test. It's a rapid antigen test. There's just not enough data about it now. What we know about the 3 rapid antigen tests that have both been EUA approved and that are in use is that one of them has an enormous number of false positives. In fact, the state of Nevada quit using it because it had more false positives than true positives. At that point, you may as well flip a coin, literally. And the sensitivity is probably, well, we know the sensitivity of the rapid antigen tests are significantly lower. So I think based on what we know now about the 3 existing rapid antigen tests, asymptomatic or for most symptomatic adults, they are just not useful. They're just not good enough. For symptomatic kids that may have more virus, they may be good, but we don't know. The other problem with these is that, I mean, this particular one, that company, they said they're hoping to have like 100,000 of them by January. That's great for the 330 million Americans. So it's a national, failure at many levels that we don't have more ready testing available.
Great. Thanks, John. Let me leave you on the live wire here for a moment and ask you a question about your work with the Medical Response Office. We've been reading about contact tracing and how some are very reticent to share who their contacts are. Did you find that the case with the Pitt students? Was it easy to trace contacts or challenging?
No, it was challenging. We found this too. And I think this is where that two-way communication is really, really important. I love the story Maya told. Similarly, for the ivory tower to just tell, communities, here's what you should do. That just doesn't work. And so we, in fact, Elise Martin, who's an adult ID doc and one of the key members of the CMR, at least called students herself on the phone sometimes. And usually, if you explain, look, this is not punitive, it's all in a secure database, it's all anonymized, we're trying to protect your friends and protect the campus and protect vulnerable members of the Pitt community. And almost always, once we explain to people the real purpose of contact tracing, people were fine with it.
Great, John, thanks. Maya, the next question comes to you, and Amy Houtrow asks, how do we help the community to understand that the vaccine isn't a panacea?
Yeah, no, I think that's a really great question. It's something that we were discussing on Tuesday as well with community members. I think it is really about providing community partners the messaging and working with them to develop the messaging and having them support the message delivery. I really truly think whenever we are doing any messaging about vaccines, we should include them early, we should include them often, and we should really lean on them to support our messaging, because they are just so trusted in the community, and they are so dedicated to addressing the disproportionate impact of this pandemic on marginalized communities. So I really think that that's the most important thing I think I've learned from the CBC, and I'm really grateful for the multiple groups of community members who are doing this work and providing messaging. So I would say just including community partners in messaging and having them support that.
Great, thank you, Maya. John Alcorn, if I could ask you one. You know, the inflammatory responses early and late evoked by SARS-CoV-2 are remarkable. And I wonder what's different about that virus that is linked to these both acute and delayed inflammatory responses. It just seems, it's not unique, but it's just unusual. So what about SARS-CoV-2?
Yeah, I think one thing that's somewhat special about SARS-CoV-2 is the fact that it has very broad tissue tropism. So it infects a broad number of cells. Almost every cell in the body expresses ACE2 at some level. So I think that part of the big difference there is, something like flu normally is attacking a fairly restricted subset of airway cells and distal lung cells. But SARS-CoV-2's ability to really hit the endothelium as well, I think, is the biggest factor. So we don't only get a large inflammatory cytokine burst in the airway, but we also get a large burst deeper in the tissue. And we also get a fair amount of vascular activation, which would lead to even more inflammatory cells coming in. So I think that that's probably the overriding or the overwhelming inflammation source.
Great. Thank you, John. Please post your questions up in the Q&A if you have them. We have a couple more minutes. Maya, I want to ask a question that I think is on everybody's mind. We're all reading about roughly 50% of the population, at least in the United States, is willing to roll up their sleeve for a COVID-19 vaccine. That's distressing. And so from your work, what do you think are the most effective means to combat vaccine mistrust?
Yeah, no, that's a really great question. And so I think, and so first of all, I'll say that that what I'm saying are ideas that have been generated from the CBC, not necessarily, just from me, but I think it's really about creating messaging that is that's understandable, that's approachable, that's sort of, and so I think like through videos and through infographics, and then also having, so I think that's one piece of it. I think the other piece of it is really spending the time to sit in that mistrust and understand that mistrust. I think what I have been hearing that is when we acknowledge and understand the mistrust to start, and then sort of use that conversation to move us forward to then discuss, vaccine safety, vaccine efficacy. But I think starting with this is a safe, and we know it is, and we all know how important it is that everyone gets vaccinated. But my sense is if somebody is feeling mistrust, really understanding the roots of that mistrust first and addressing those concerns, and then kind of moving forward and talking about the safety and efficacy can be really helpful, especially with the COVID-19 vaccine. And then I'm going to sound like a broken record, but I think definitely, making sure that we run our messaging by community partners and include them in whatever we do, because they have just been really instrumental, I think, in providing trusted information to the community. So I think that can be very helpful. But that's my sense, is really starting with the sitting and reflecting in the mistrust, and then sort of using that to shift the needle to like, okay, how can we provide you trustworthy information?
Terrific, Maya. Thank you. John, let's make the last John Williams, let's make the last question to you. Do you know if there's a process to document vaccine side effects to the healthcare workers who are immunizing now? And do we anticipate rolling this out to eventually all vaccinees when we have enough COVID-19 vaccine to immunize the population?
Yeah, so my colleague Mike Green informs me that, because he saw that question, he's fairly sure that UPMC has a follow-up email that will be sent to vaccinees. So for the short term, that is important. Number two, it's important for people to realize that all vaccines have like any other drug, phase 4 post-licensure or post-availability surveillance. And so any adverse event that is thought to be or possibly associated with vaccine can and should be reported. You know, if I get a flu shot and the next day get in a car wreck, I can report that myself as a private citizen to VAERS, Vaccine Adverse Event Reporting System. And VAERS is a giant database that records all this stuff. And it would see if there's a pattern. Wow, 100 people who got the flu shot had a car wreck. Maybe there is an association. So it will be followed closely, and people should report anything. I would just caution people at being overly alarmed by, 3 reports now of patients with allergic reactions. Allergic reactions, in fact, fatal allergic reactions happen to shrimp all the time, and nobody's not eating shrimp. So it's under a microscope. People are laser focused on this vaccine appropriately. But to have, with the now thousands of people vaccinated, to have a couple of people with allergic reactions, that's not at all surprising. And it wouldn't make the news, except that we're also laser focused. So I think everybody should just, press on and keep a close eye for significant adverse events.
Terrific. John Williams, John Alcorn, Maya Ragavan, thank you again for your presentations. At my count, at least, we had a high water mark of 177 attendees for Grand Rounds this morning. That's terrific. Those who have time, please join in the meet and greet to discuss further COVID-19 developments with John and Maya. And I'll sign off now and wish you all a safe and happy holiday. Of course, it's going to be different this year, but do try and connect as much as you can with your mask on, as John Williams is showing us how to do. You all take care. Have a good rest of Thursday. Bye now.
Bye-bye.